Hello students, let's study spirochetes. So now see classification. Spirochetes divided into Spirochetaceae. The examples are Treponema and Borrelia. And the second family Leptospiraceae. The example is Leptospira. So spirochetes are small, motile, slender, helically coiled, flexible bacteria. Require special staining. Gram stain is ineffective. So special methods like dark field microscope, fluorescent microscope, silver stain for tissue, right or GIMSA may detect Borrelia in blood smears. So the pathogenic spirochetes, first is treponema. So the treponema pallidum causes syphilis, transmission sexual. Treponema pertinue causes cirrhosis and transmission direct contact. Treponema endemicum, the disease endemic syphilis, direct contact. Treponema caretium, the disease is pinta, and the direct contact. The second species is Borrelia. Borrelia recurrentis, relapsing fever epidemic, louse-borne. Borrelia dattoni, relapsing fever endemic, pig-borne. Borrelia burgdorferi, Lyme disease, pig-borne. Borrelia vincenti, Vincent's angina, direct contact. The third one is Leptospira. Leptospira interrogans, leptospirosis, mild and severe form, Wills disease, contact with rodent urine. Let's now, students, let's study treponema. So in that, treponema pallidum, which causes syphilis, treponema pertenue, which causes cirrhosis, and treponema caretium, which causes pinta. So treponema pallidum, characteristics discovered by Shodin and Hoffman in 1905. Better seen under dark-ground microscope, prolonged GIMSA stain, silver impregnation method, Fontana for smear, and lividity for tissue section. Morphology thin, 10 micron with tapering ends. Culture do not grow on artificial media. Virulent strains can be maintained in rabbit testes by serial passages. Nicole strain used for diagnosis and research. Ritter strain, non-pathogenic strain cultivated for diagnosis. Smith-Noguchi medium under strict anaerobic conditions. Pathogenicity, venereal syphilis, sexually transmitted disease, entry through minute abrasion on mucosa or skin, spread enters the lymphatics and blood to produce systemic infection and metastatic foci. Incubation period about a month. Infectivity is maximum during first 2 years of disease. The stages are primary, secondary, latent, tertiary, quaternary. Primary syphilis, hard chancre on genitals, painless, avascular, circumscribed, indurated, and ulcerated lesion covered with thick, glary exudate rich in spirochetes. Sites, penis in males, cervix labia in females, anal canal, rectum, mouth in homosexual. Regional lymphadenopathy heals spontaneously in 10 to 40 days. Secondary syphilis, most infectious stage, skin and mucous membrane involved, sets in 2 to 6 months after primary lesion healed. It is asymptomatic but widespread dissemination occur via blood. Maculopapular skin rashes on the body, mucus patches in the oropharyngeal area, and condylomata at mucocutaneous junctions. Generalized lymphadenopathy, one-third cases chancre persist. Latent syphilis, quiescent stage which follows secondary stage, absence of clinical manifestation but positive serological test, patient still infectious. Fate of latent syphilis, persistent lifelong infection which is common, development of late syphilis, spontaneous cure. The fourth is the tertiary syphilis after 10 to 20 years, gamma, cardiovascular lesions like aneurysm, aortitis. Quaternary syphilis, neurosyphilis, tabes dorsalis or general paralysis of insane, meningeal syphilis. Congenital syphilis, mother to fetus via placenta after 4th month of gestation. Clinical features, keratitis, saddle-shaped nose, Hutchinson's teeth, 8th nerve deafness. Laboratory diagnosis, microscopy, dark ground microscope in first primary and secondary syphilis, silver staining, direct fluorescent antibody test. Serology, mainstay of diagnosis. Non-specific test, standard test of syphilis, group specific test and specific test. Direct microscopy demonstrate treponema from sites, superficial lesions of primary, secondary. Dark ground microscopy, silver staining, tissues, lividity and Fontana test, stain, direct fluorescent antibody test. Non-specific standard test for reagent antibody using cadolipin antigen. Wassermann complement fixation test, Kahn flocculation test, VDRL RPR test. Biological false positive reactions are seen in 1% of human sera. Difference between VDRL and RPR. So VDRL slide flocculation, VDRL antigen, cadolipin antigen, reagent antibodies. RPR slide flocculation, RPR antigen is cadolipin antigen carbon coated and reagent antibodies. Sample VDRL blood plasma serum CSF, RPR blood plasma serum no CSF. Procedure 4 minutes rotation, RPR 8-minute rotation. VDRL microscope is required for the result. The result can be seen by naked eyes. VDRL cheaper, RPR costly. Disadvantage of VDRL antigen reconstitution, serum preheating required. RPR not required. Use VDRL screening test in ANC, RPR blood donor screening. Advantages of non-treponemal test. To monitor the response to treatment, detect neurosyphilis, reagent antibodies detectable 7 to 10 days after appearance of primary chancre, sensitivity 78 to 85% in primary, 100% in secondary, 95 to 98% in latent stage. Disadvantages of non-treponemal test by biological false positive reactions. False positive occur in 1% normal sera, like conditions lepromatous leprosy, relapsing fever, malaria, viral hepatitis, HIV, pregnancy, infectious mononucleosis, autoimmune diseases, prozone phenomenon, false negative. Group specific test using Ritter anti-strain antigen, Ritter protein complement fixation. Specific test using Nicole strain, live PPI, Treponema pallidum immobilization, killed FTA ABS, fluorescent treponemal antibody absorption test, IgM FTA ABS, congenital syphilis. Extract TPHA, Treponema pallidum hemagglutination, TPPA, Treponema pallidum particle agglutination. Penicillin drug of choice, second line erythromycin, tetracycline, doxycycline, neurosyphilis, ceftriaxone. Prevention, screening all pregnant women at first prenatal visit, individuals with other STDs, high risk behavior, drug use, prostitution, etc., exposure, reporting of contacts and tracing of sexual partners, education. Treponema pallidum. Treponema pallidum is thin, delicate spirochete with tapering ends. It has about 10 regular spirals, actively motile. Motility, flexion, extension, corkscrew motility, soft bending at the right angle to the midpoint. Pathogenicity, syphilis. Mode of transmission, sexually transmitted disease acquired by sexual contact. Spread spirochetes enter body in minute abrasion or skin or mucosa and enter lymphatics and blood and multiply and produce systemic infection. Clinical stages, primary heart chancre, single painless papule, ulcerated, indurated, covered by thick exudate rich in spirochetes. Common site, penis, cervix, labia. Heal within 4 to 6 weeks. Regional lymphadenopathy, usually inguinal. Painless, firm, non-suppurative, often bilateral. Secondary syphilis develops 4 to 8 weeks after healing of primary lesion. Skin and mucous membrane commonly affected. Skin rash, palm and sole. Roseolar and papular skin condylomata at mucocutaneous junctions. Latent syphilis, it is period of quiescence, no symptoms, but serologically test can be detected. Patients are still infectious. Tertiary syphilis, gamma, late benign syphilis, locally destructive granulomatous lesion, bone and skin. Neurosyphilis, meningeal syphilis, meningitis, meningovascular syphilis, general paralysis of insect, tabes dorsalis. Quaternary syphilis, cardiovascular syphilis, aneurysm of ascending aorta and aortic regurgitation. Congenital syphilis, residual stigmata, Hutchinson teeth, notched central incisors, mulberry molar, saddle nose, Shaber shins. Laboratory diagnosis of syphilis: sample exudate from superficial lesion in primary, direct microscopy, dark down microscopy, slender, flexible, spirally coiled bacilli with tapering ends. It is actively motile. Direct fluorescent antibody staining, green fluorescent bacilli against the dark background, silver impregnation staining, increased thickness, lividity stain for tissue, Fontana stain for smears. For secondary syphilis, we can do VDRL and RPR test. Cultivation maintained by subculture in rabbit testis. Serology antibody detection in secondary, tertiary, quaternary syphilis. Non-treponemal test and treponemal test. So non-treponemal tests are also called standard test of syphilis. Antigen, cardiolipin, bovine heart, VDRL and RPR. Disadvantage: biological false positive is seen in lepromatous leprosy, malaria, relapsing fever, viral hepatitis, HIV. Treponemal test, specific test. Rabbit test is Nicole strain. Live TPI, Treponema pallidum immobilization, killed FDA ABS, fluorescent treponemal antibody absorption test, IgM FDA ABS, congenital syphilis. Extract TPHA, Treponema pallidum hemagglutination, TPPA, Treponema pallidum particle agglutination, molecular PCR. Hello students, let's study Leptospira. So there are the pathogenesis three important epidemiological determinants for leptospirosis: exposure to rodents, rainfall, and rice field. Two distinct phases of pathogens involving the leptospiral infection. First phase, septicemic phase. After entering through the mucosa, conjunctival or oral or abraded skin, leptospira introgons spill over to the bloodstream and then disseminate hematogenously to various organs. Vascular damage: spirochetes can be found in walls of capillaries, medium large sized vessels. Exact mechanism is unknown. Penetration and invasion of tissues is due to active motility and release of hyaluronidase. Second phase, immune phase. As antibodies develop, spirochetes disappear from the blood. Antigen antibody complexes are deposited in various organs. Renal colonization. Bacilli become adherent to the proximal renal tubular brush border and excreted in the urine. So clinical stages: first stage 3 to 10 days, septicemic stage. In that, fever, myalgia, headaches, and conjunctival suffusion, abdominal pain, pharyngeal erythema without exudate, vomiting. Second stage 10 to 30 days, immune, meningitis, no, uveitis, optic neuritis, chorioretinitis, rash, fever, peripheral neuropathy. So these are in the mild and ecteric febrile illness. That is first stage and second stage. After that, the Bill's disease. In that, first stage is septicemic stage. In that, high-grade fever, liver jaundice 5 to 10%, raised liver enzymes, hemorrhages, pulmonary, particularly purpura, conjunctival hemorrhage, gastrointestinal hemorrhage, kidney, raised serum urea creatinine, and renal failure. Second stage is the immune phase. So in first stage, isolation from blood and CSF, then serum IgM absent, antibiotic susceptible to antibiotics. Second stage, isolation from urine, serum IgM present, refractory to treatment. In Wills disease, first stage, the isolation from blood and CSF, the serum IgM absent, susceptible to antibiotics. Second stage, isolation from urine, IgM present and refractory to treatment. So to summarize Leptospira is antigenically complex, comprises of two species, Leptospira introgans and the biflexa. Biflexa is the commensal flora. Morphology: Leptospiras are actively motile, delicate spirochetes. They have large number of closed spirals and hooked ends. They are very thin, not seen under light microscope. They are seen under dark ground microscope or electron microscope. Pathogenicity: leptospirosis, zoonotic disease. Source: rats, dogs, cattle, pigs. Man is infected when leptospirosis in water contaminated by urine of animals enter body through cut skin, nose, mouth, or conjunctiva. Clinical manifestation: mild unecteric febrile illness 90%, biphasic septicemic phase and immune phase. Wills disease, hepatorenal hemorrhagic syndrome 10%, severe form of ecteric illness, present complications, meningitis, bleeding. Laboratory diagnosis: specimens first 10 days CSF, blood, urine between 10 to 30 days, urine. Microscopy, wet films, dark ground or phase contrast microscope, staining, silver impregnation stain, Fontana stain reveals spirally coiled bacilli, tightly and regularly coiled with characteristic hook ends like umbrella handle. Isolation, culture condition 32 degrees Celsius for 4 to 6 weeks. Medium EMJH, Ellingausen, McCullough, Johnson, Harris, medium. Korotkov or Fletcher and Stewart's medium. Serology for antibody detection, serovar specific test, microscopic agglutination test, gold standard test detects antibodies against specific serovar of the L interrogans. Microtiter plate patient serum plus live antigen suspension of various leptospiral serovar endemic in the locality, incubated for 2 to 4 hours at 30 degrees Celsius, then examined under dark ground microscopy for presence of agglutination. Immunochromatography test, it detects IgM and IgG antibodies. Molecular PCR, non-specific, LFT and RFT deranged. Hello students, let's study Borrelia. So Borrelia, most species occur as commensal on the buccal and genital mucosa. Human pathogens, Borrelia recurrentis causes epidemic relapsing fever. Borrelia burgdorferi causes Lyme disease. Borrelia vincenti causes Vincent's angina in association with fusiform bacilli. Relapsing fever, recurrent episodes of fever and non-specific symptoms, hemorrhages, petechiae, epistaxis, and blood-tinged sputum. Neurologic features, meningitis, seizure, focal deficits, paraplegia, and psychosis. Two types, epidemic and endemic relapsing fever. Epidemic relapsing fever caused by Borrelia recurrentis and transmitted by louse. Endemic relapsing fever caused by Borrelia species other than Borrelia recurrentis, such as Borrelia duttonii, transmitted by tick. Lyme disease transmission, tick bite, stage 1, early localized infection, annular maculopapular lesion at the site of the tick bite, erythema migrans. Stage 2, early disseminated infection. Stage 3, late persistent Lyme arthritis. Vincent's angina, acute ulcerative necrotizing gingivostomatitis, inflamed pharyngeal mucosa covered by grayish membrane, peels off easily. Agent Borrelia vincenti in association with Leptotrichia bacchalis and anaerobic gram-negative bacillus, spindle-shaped with pointed ends. Lab diagnosis for relapsing fever, microscopy, peripheral thick and thin smear, stain by Wright or Giemsa stain, direct fluorescent antibody test, direct ground microscope, quantitative Buffy coat analysis, poorly gram-negative. Lyme disease, isolation of burgdorferi, cultured skin lesions, blood or CSA, Barber Stoner Kelly medium, incubated at 34 degrees Celsius, dark field microscope, weekly for 2 months, molecular methods PCR, Vincent's angina, laboratory diagnosis, demonstration of spirochetes and fusiform bacilli in stained smears.
Hope you find this session useful for your understanding and for your exams. Thank you.